Good afternoon and good evening to those on the East Coast. Also, my good thoughts and prayers for those that are in the path of Hurricane Ian. Armando Contreras here. I'm the president and CEO of United Cerebral Palsy, and it's my pleasure to welcome you to our latest webinar in UCP's Professional Learning Series. The series is hosted by our partners at Gillette Children's, UCP of Minnesota, UCP of Central Arizona, and the UCP Research Committee. If you're not familiar with our association, UCP is a network of 56 affiliates in the US and Canada, providing vital services to children, teens, and adults with cerebral palsy and a wide range of other disabilities. We're proud to say that hundreds of people have attended these series of webinars over the past year and a half. Today, we have more than 150 individuals that are registered. That includes practitioners in the field, at many of our affiliates, self-advocates, family members, and the general public. These expert presentations focus on early intervention and other types of research. Before I hand over the mic to UCP's Research Committee co-chair, Valerie Piercini, I want to congratulate her, Dr. Michael Kruer, and the United Cerebral Palsy Research Committee for its work this year in administering UCP's first grant program for research into cerebral palsy and related neurodevelopment disorders. Early this month, 4 organizations across the country were awarded research grants of $20,000 each, and one of those grants went to Gillette Children's in St. Paul, Minnesota. Planning is underway to replicate the grant program in 2023. Details on that, including criteria and deadlines to apply, will be publicized early next year. Thank you again for joining us tonight. I will now turn it over to my colleague, the co-chair of UCP's Research Committee, Valerie Piercini, also director of the Early Intervention and Therapy at UCP of Central Arizona. Valerie, the floor is yours.
Thank you, Armando. So on behalf of UCP's Research Committee, I want to thank you guys for all attending this session of the Professional Learning Series. Along with Dr. Michael Kruer, as Armando mentioned, I serve as the co-chair of the UCP Research Committee. Our charge is to explore and promote transformative research that changes the way we think about and care for individuals with cerebral palsy and other neurodevelopmental disorders. So today's speaker is Dr. Michael Kruer, who will be presenting. The title is New Discoveries, as you can see here, in the Evolving World of Genetics, Diagnosis, and Treatment of Cerebral Palsy. And actually, this is a part 2. He presented approximately a little over a year ago. So things are changing rapidly, and we're excited to hear. Just before I introduce Michael, I did want to just remind you that this meeting is being recorded. We won't be taking presentations during questions during the presentation, but you're more than welcome to post your questions just by clicking on the chat at the bottom of your screen. And the live Q&A session will begin immediately after. So to introduce Michael Kruer is an honor. He is a good friend and colleague, and being co-chairs has been quite a journey, and it's been a great journey. So Michael is a pediatric movement disorders specialist neurologist and a human geneticist. He serves as an associate professor of child health, genetics, neurology, and cellular and molecular medicine at the University of Arizona College of Medicine here in Phoenix. He also serves as the director of the Pediatric Movement Disorder Program at the Barrow Neurological Institute, Phoenix Children's Hospital. And Michael's lab is dedicated to understanding how genetic mutations lead to both common, so cerebral palsy, and rare movement disorders in children, and how genetics can really serve as a springboard to improvements in both diagnosis and intervention, which is much of what he's going to be sharing with you today. I also want to brag that he received the Laura Dozer Award from UCP of Central Arizona, which is where I'm from and my affiliate, just a few years ago for promoting a life without limits for individuals with disabilities. But I would also tell you that he received that because he is a much loved doc in this community. and a great person to be able to collaborate with in the care of children. His research has been supported by numerous public and private foundations, and philanthropy, industry collaborations, federal grants, and has appeared in a number of highly respected publications, which has been exciting with all that's happening within this field. The Kruer Lab is currently collaborating with a Cerebral Palsy Research Network, or CPRN, on an NIH-funded study of CP genomics, whose goal is to better understand the causes of CP in order to personalize treatment to people with CP. So at this point, Michael, I'm going to turn it over to you, and I'm going to mute, and we're excited to hear what you're going to share.
Thanks so much, Armando and Valerie, for the kind introduction. And I really have to say the pleasure has absolutely been mine. It's been such a privilege to be involved with UCP and to serve on the research committee. So as Valerie mentioned, I'm going to be speaking to you today in a continuation of a talk that I gave about a year ago, where I discussed some of the emerging genetic contributions to CP. During that first talk, I introduced some of the fundamental genetic concepts and their relevance to CP, and really focused on how some of these new genetic concepts were changing our ideas about how CP is caused and how CP comes to be. Today, I'm going to focus on a slightly different area, really emphasizing some of the practical clinical considerations that are relevant to many of us who see children and adults with cerebral palsy. So here are disclosures, and I'm going to begin with some background. So as was mentioned, unless you've been living under a rock for the last couple years, you might have heard that genetic mutations do lead to a substantial proportion of CP cases. This photo, remarkably, is an actual town built under a rock, the Centennial de las Bodegas in Spain, which I have to visit someday. But really, in the last few years, we've seen a small explosion of papers that have identified strong genetic contributions to CP. Here's our paper that was published now almost 2 years ago in Nature Genetics. And here are some papers from some wonderful colleagues and collaborators, including the group at Columbia and at Boston Children's Hospital, finding similar things that for a substantial number of individuals with cerebral palsy, a genetic mutation, often in a single gene, will actually represent cause for their symptoms. And this has really kind of changed the way we look at some of the causes of CP. Now, some of you might be saying, okay, well, what exactly do you mean genetic? And I know that we have a mixed audience, so I'm going to take just a moment and go over some genetics fundamentals. So when we talk about genetic conditions, it goes back to this idea that all of us have a blueprint for how our bodies should grow, develop, and function. And that blueprint essentially is our genome. And it can be thought of as a master cookbook for each of our bodies that contains a number of recipes, around 20,000 to be exact. And if you think of each of those recipes as a gene, that gene will encode for a certain program or a certain set of instructions that will help our bodies to function normally. Now, those genes, in turn, are written in the DNA alphabet. And so it's that string of DNA base pairs that actually comprises the DNA code. And ultimately, it's that DNA code that every cell in our body reads in order to form a protein, which is a form of biological machine that's utilized to do the daily work of our cells and our tissues. Now, issues can arise if there is a misspelling in that genetic code. And the two main types of misspellings or mutations that we see include copy number variants, which essentially can be thought of as pages either duplicated, completely torn out of that recipe book or that genome, or single nucleotide variants, which can be thought of really as typos. Remarkably, single nucleotide variants can sometimes affect just one base pair out of the 3 billion or so in an individual's human genome. And sometimes that can still represent the difference between health and disease, or a condition like cerebral palsy. So when we talk about the genetics of CP, one of the questions that often comes up is, well, are we talking about genetic risk factors? Or are we talking about genetic causes? And I think a lot of the very early work in this area looked at predispositions. So genetic changes that might predispose a child to be born prematurely, for example. In contrast, some of the more recent work on CP genetics has had a slightly different focus. And in this case, we've been looking at large effect size mutations. And what I mean by this is that with most of the recent work, we've been looking for single gene causes of CP. So if one gene out of the 20,000 contains a typo or a misspelling, a mutation, that mutation is enough in and of itself to tip the scales and to cause cerebral palsy. Now, this is the scenario with so-called single gene or monogenic forms of CP. And that's primarily what I'm going to be talking about today. But I think it's quite exciting that we're also starting to see an evolution. And there is a definite effort underway by my group and many others to look at all of the potential risk factors for CP in combination alongside each other. So one of the questions that often comes up with this explosion of genetic findings in association with CP is a good one. It's the so what question, essentially asking if genetic findings can impact diagnosis and treatment in CP. And so in response, I'd like to take you through a couple of cases that illustrate some of the concepts that are starting to become more and more recognized. So the first case is a 5-year-old boy with CP admitted to the hospital with respiratory distress. This boy's respiratory symptoms stabilized with oxygen and supportive care, but his dyskinesia or chorea worsens considerably during his illness. He's treated with several medications that lead to some improvement in his chorea, but unfortunately he becomes extremely fatigued and sleepy, and his respiratory drive worsens. He's urgently transferred to the intensive care unit. And there, rapid whole exome sequencing, or genetic testing, discloses a de novo pathogenic mutation in the gene GNAO1. So this was thought to represent the cause for his symptoms. After careful discussion with his parents, the decision is made to place a deep brain stimulator. And after surgery, he's able to be weaned from the ventilator. His chorea is controlled, and sedating medications are able to be weaned. And I should mention that even though this is a rather extreme example, all of these cases are in fact based on real events. And so I think that this particular case really highlights that genetic findings are starting to lead to new insights that can sometimes guide treatment decisions, and sometimes in real time for the patients that we care for. So moving on, we're going to talk about another case now. A 6-year-old girl with a diagnosis of spastic quadriplegic CP who was born at 27 weeks, estimated gestational age. And her mother becomes concerned that the botulinum toxin injection for hypertonia now making her tighter. She's experiencing daily painful muscle contractions that limit her ability to participate in therapy. And a repeat MRI is performed and shows the appearance of iron deposits in the brain, suggesting that she may not have CP after all, but a CP mimic. In this case, genetic testing is performed and identifies pathogenic mutations in the PANC2 gene. This genetic mutation is known to be highly associated with dystonia. And so her tone is reevaluated and found to actually represent dystonia. And this prompts a change in her medications and an adjustment of her therapy goals. It's also recognized that the dystonia often can work time in these individuals. And so the botulinum toxin injections are continued as a valuable part of her treatment plan. And so in this case, I think this may serve as an example that genetic results can sometimes clarify what are, particularly in the beginning, confusing clinical pictures. Sometimes it can help us to understand what we're seeing and help us to place our observations in the right context. Finally, a third case for you guys. This is a 7-year-old boy who was born at 30 weeks gestation, diagnosed with spastic diplegia just after his first birthday. His MRI shows periventricular leukomalacia, and his clinical course is stable, but he shows a partial response to oral medication, botulinum injections, and physical therapy. Genetic testing, and this shows a pathogenic mutation in the SPAST gene. And this has classically been associated with hereditary spastic paraplegia, which is a progressive disorder. However, noting his stable course, his preserved strength, and good selective motor control, his CP team proceeds with a selective dorsal rhizotomy with excellent post-op outcome. And I think what this case really emphasizes is that genetic results may not change what we already know. And so in thinking about SDR candidates, we know that individuals with stable courses, good strength and selective motor control often represent our best candidates. And in this particular example, this was exactly the case. So this really brings us to the WH questions in regard to CV genetics. So these are being increasingly asked by clinicians, and I think are more relevant now than ever before. But the who, what, when, where, and why of genetic testing in CP is what I'm going to be spending the next few minutes to go over. So first of all, who? One of the major questions that I often get is, should we test all CP patients or only selected individuals? And I think this is particularly a confusing time to be a clinician, because I think that concepts of CP genetics are actually in a state of flux. Interestingly, experts have made recommendations on both sides of the fence, with, in this particular case, one arguing that selected individuals should get genetic testing. And in the bottom example, this article argued that everyone with CP should get genetic testing. So what is a busy clinician to do? And I think that this is particularly challenging at this moment in time because really the research knowledge that we have has advanced faster than clinical standards of care. And so, for example, if you look at the practice parameter from the Child Neurology Society and the American Academy of Neurology, it makes a statement that there's no role for genetic or metabolic testing in the diagnostic assessment of the child with cerebral palsy. However, this practice parameter is now more than 15 years old, and efforts are underway to update these recommendations. But what do we do now with the patients that we need to see, particularly as the evidence base continues to build? And I'll be quite honest with you, there's no easy answer to this question as to who should be tested. Some individuals will argue, some experts will argue that individuals that so-called cryptogenic CP with no other recognized risk factors for their cerebral palsy would be the best to test. And I think many would agree with this. There's also been some literature that suggests if an individual has concurrent neurodevelopmental disorder, such as intellectual disability, autism, or epilepsy, for example, that also increases the likelihood that that person will test positive for a genetic cause for their symptoms. However, we also know that many individuals who have isolated CP without other neurodevelopmental findings will also test positive. So while we're waiting for additional data to emerge that will help to inform practice, right now, my current recommendation is certainly to test if there's not a clear etiology. However, I think that for each and every patient that comes into our clinics, we need to carefully consider their individual case. And so this is one of my favorite recent examples, but this is taken from a review article. And what you can see here in the panel are a series of MRI scans. You can see irregular contours of the ventricles. In some cases, you can see injury patterns that suggest a prior stroke. You can see white matter hyperintensities that include periventricular leukomalacia in addition to other findings. You can see more complex malformation sequences that represent porencephaly or schizencephaly or even polymicrogyria. However, even though all of these different conditions, these different MRI features are recognized to be associated with palsy, What's quite remarkable to me is that even though many of these patterns are thought of as so-called acquired injury patterns, that each and every one of these individuals, in fact, had mutations in a single gene, and the same gene, even though their MRI scans actually looked quite different. And this was the gene called for A1, which happens to heavily influence cerebral vascular development. And so I think the picture is currently becoming even more complicated. But I think that at this point in time, simply considering each case individually is the best way to go. Moving on just slightly to what should be done. This asks the question, what sequencing or what testing should we do for individuals with cerebral palsy? And we can certainly start with single gene sequencing. But what I think is becoming increasingly evident is that there are likely hundreds of different genes that may lead to CP. This really tells us that as a clinician, you'd better be either really lucky or really good. Or you might end up with a scenario like the one seen with the dartboard on the right. And because of this, many clinicians have really moved to unbiased testing many genes at once rather than going gene by gene to try to find an answer. On this note, chromosomal microarrays are valuable tests that allow clinicians to detect those genomic copy number variants. Again, looking for duplications or pages torn out of that genomic recipe book, the CP. In addition, there are also gene panels that are currently available. There are 2 commercial CP panels that are available for clinical use. And I think that increasingly, the field is also moving towards whole exome and even whole genome sequencing. And the benefit is that although the commercial CP panels will test for several hundred genes all at once, that by no means encompasses all of the possibilities. And so whole exome or whole genome sequencing is literally looking at all of the genes. I think that the field is slowly moving in this direction when one considers other neurodevelopmental disabilities as well. And so on the right, you can see a recent practice parameter from the American College of Medical Genetics and Genomics that really advises that exome sequencing and genome sequencing are top-line evidence-based recommendations for individuals with either congenital anomalies or intellectual disability. I think we may ultimately see something similar for cerebral palsy. So when should we test? Well, I think that ideally testing should be done at the time of diagnosis. However, with that said, unless you've been living under another rock, you also recognize that there is an increasing emphasis on early detection and that implementation work aimed at identifying children early is increasingly occurring. And I think that this is going to mean that we're going to be performing this testing earlier and earlier. Furthermore, for many of the individuals that already have an diagnosis of CP, we're in a catch-up phase. And so they may be teenagers or adults, but in particular, if the cause of their CP symptoms is not known, genetic testing might be appropriate for some of those individuals now. Where should this testing be performed? Well, many clinicians will defer to our expert colleagues in clinical genetics and genetic counseling. After all, these are our medical genetics professionals. However, I think that like many subspecialties of medicine, there are simply not enough of these individuals. And in many centers, their availability is limited. And so the growing demand for genetic medicine really indicates that we're going to need to apply other solutions as well. And so other specialties may certainly contribute, in particular, specialists that serve as part of the medical home for individuals with cerebral palsy. Now, it's been argued that child neurologists and neurodevelopmentalists may be particularly well suited to the diagnostic workup of individuals with palsy. But I think that practitioners from a broad variety of specialties, including developmental pediatrics, PM&R, orthopedics, neurosurgery, and complex care, among others, can certainly also contribute to the diagnostic assessment of individuals with CP. And I think it really depends upon individual provider comfort and their role in the overall care of that individual. So an important question that it's best not to gloss over is why do genetic testing for individuals with CP? Well, this is a summary table from an excellent article written by my friend and colleague, Julie Cohen at Johns Hopkins. And Julie lists a number of potential benefits to genetic testing for individuals with CP and related neurodevelopmental disorders. And this includes the ability to end a diagnostic odyssey, a series of tests looking for answers for the family. Genetic testing can provide a name that connects all the child's symptoms. It can allow us to predict what their future may look like, even if we don't have a crystal ball. Excitingly, and I'll talk more about this in a few moments, this may allow us to actually tailor our medical treatment. And it can, in many cases, alleviate negative emotions where the family, particularly the parents, may blame themselves for something they did or did not do. Increasingly, we're seeing condition-specific support groups springing up and connecting with one another. And I think that recognizing a cause can be very, very helpful for families with a child with CP, because it can also allow us to counsel them effectively about their relative risk of recurrence if they have another child. So I want to spend some more time now, though, talking about a potential role for personalized medicine in CP. Some of you may have heard this statement that if you've seen one patient with CP, well, you've seen one patient with CP, meaning that patients with CP can be remarkably different from one another. And this is sometimes taken to the extreme, leading Terry Sanger to ask this question in an editorial a number of years ago in the Journal of Child Neurology, taking on the question, is cerebral palsy a wastebasket diagnosis? And in this article, Terry argues very eloquently that CP absolutely represents an appropriate diagnosis if used appropriately, but that we do need to recognize the heterogeneity of CP, that one person with CP may be very different than the next. And so perhaps cerebral palsy being a wastebasket diagnosis is not true, but nevertheless, a one-size-fits-all approach may not be effective. So I think that many of us in clinical practice will recognize this. So imagine a mixed group of individuals with cerebral palsy showing similarities to one another to the point that the diagnosis of CP is appropriate, but also showing important differences from each other. And so this contributes to much of the mixed response that we'll often see when treating individuals with CP. Sometimes we'll try something and it'll work beautifully. Other times we're frustrated by the outcome, even though we apply the same intervention. And I think just if you can think about these individuals as individuals, recognizing that, sure, they all have CP, but that there's more to their story is, I think, more relevant than ever. So, for example, this mixed group of individuals with CP may, in fact, have very different gross motor functional scores, classification scores. So differences between GMFCS1 and GMFCS5 are well recognized. The topography or the distribution of symptoms may be very relevant. Individuals with hemiplegia may differ quite a bit from individuals with diplegia, for example. As a movement disorders neurologist, I would argue that the individual's movement disorder may be very relevant to their treatment plan. And that, for example, individuals with spastic cerebral palsy may have very different needs at some level than individuals with dyskinetic forms of CP. I think many of us have had the experience that some of the associated symptoms, some of the concurrent neurodevelopmental diagnoses may be very relevant. So, for example, if a child has visual impairment, that may impact his or her response to therapy and may require that therapy be adapted in some way. Similar with hearing loss. And many of us have also experienced situations where children hit plateaus when their seizures get out of control, but that they may be in a better place once those seizures are again under control. Finally, I think had the experience that there are some important differences about individuals with very good preserved purposeful movement versus those individuals that have very little purposeful movement. And so just the way that each of these pieces of information can help us to look at an individual with CP, better understand where they're coming from, and then better help them to get where they want to. I think we're starting to wonder whether we might use newer tools, particularly technology-driven tools, to help to separate out important differences that can help us treat people with CP better. And really, this comes down to seeing the whole picture. So this is one of my favorite kind of stories of the blind man and the elephant. And essentially, this is an old Indian parable, if I'm not mistaken, that says that there are 6 blind men who come across an elephant while walking through the jungle. And each one reaches out and touches a different part of the elephant. One touches the tail and is convinced that he rope. Another grabs the leg and is certain that he is hugging a tree trunk. Similarly, with CP, I think that we can all look through slightly different lenses and perhaps see the same thing in a different light at times. So where one individual may see CP, another may see dystonia, another may see dyskinesia. In another case, that child might be labeled as having motor delay. In yet another, hypertonia. And in perhaps another example, psychomotor retardation. And yet all of these individuals are essentially describing the same thing. I think this argues that a common language is more important now than ever, and there needs to be consistency across different disciplines and different specialties. And I think that this is particularly important because we're now seeing things through the genomics lens. And going back to this idea that there might be differences in how individual patients will respond to therapies. If you think of that mixed group of individuals with CP, I'm going to argue over the next several slides that it may in fact be possible to use genomics or information to actually separate out important differences among that group of people with CP. And in some cases, this may allow us to repurpose existing treatments, meaning that we might be able to actually use non-CP medications for that individual's CP care. And I'll give an example of that in just a few slides. In other cases, the genetic information will give us valuable insight that will allow us to potentially avoid a complication through. In other cases, the genetic information may allow us to reach for highly effective treatments rather than having to go through the usual trial and error that I'm so used to as a clinician. In yet other cases, we might find that the genetic information doesn't necessarily change what we're going to do, that individual might have a good response to conventional therapies. And I think in still other cases, we might see that genetic information really tips us off that the existing treatments that we have are not going to work well for that individual, and we need better therapy options. So in thinking about this further and thinking about how genetic information could actually change management, one of my favorite examples of potentially reaching for the best treatment first was described by our UCP Research Committee member, Darcy Failings, and her colleagues in Toronto. And they actually found that for an individual that had mutations in CTNNB1, one of the most common genetic forms of cerebral palsy or causes of cerebral palsy, this actually affects early dopamine neuron development. And they published this very nice report in Movement Disorders showing that levodopa treatment actually improves symptoms for individuals, could improve symptoms for individuals with this particular genetic form of CP. In the future, allowing other clinicians to reach for the best treatment first. Another example, as I mentioned a moment ago, is the possibility of repurposing existing treatments. And so what do I mean by this? Well, many of you are aware that we use caffeine in the neonatal ICU for infants, premature infants in particular, with apnea, among other things. Well, you might not be aware that caffeine actually can be used to treat CP-related symptoms as well. And so this came out of a remarkable report published a few years ago by our colleague Emmanuel Rose and his colleagues. And they actually found that individuals with mutations in the 85 gene developed a dyskinetic form of cerebral palsy, and that the chorea associated with this dyskinetic form of CP was actually remarkably responsive to caffeine, to the point that his index patients were drinking double espressos several times a day, and that was enough to control their symptoms to some extent. Now, this was picked up by a number of news outlets who might have exaggerated the story a little bit, but nevertheless, I think this is a particularly poignant example of how sometimes we can think outside the box once we have new insights from genetic information that allow us to approach an individual's CP from a different angle. And I think that over time, we're going to increasingly see examples of repurposing existing treatments for cerebral palsy. I think there are potentially exciting opportunities to predict responders. And so one of my favorite examples of this is deep brain stimulation. Those of you who have heard me speak previously might have heard me say that DBS can be a wonderful therapy for patients with CP, particularly with dystonic CP. However, on an individual basis, the DBS may work beautifully or not as well as we hoped. And so one of the most difficult jobs that I find myself having to tackle is counseling families appropriately when they're trying to decide if their family should undergo what essentially is an elective brain surgery to try to improve their child's symptoms. So what we're finding is that in some cases, data can help us predict who responds to DBS and who may not. And although we still have a long way to go, efforts such as the PD-DBS Consortium are underway to try to parse this out. Over time, this may give clinicians valuable information that allows us to better counsel families based upon what we know about individuals with a specific genetic mutation and how they may or may not respond to DBS. Additionally, we're starting to do treatments. And so this is something that's being increasingly recognized in the neurology of rare disorders world. But I think that more than ever, there may be an opportunity to start to think about innovative new trial designs. And one of my favorite examples of this are so-called N-of-1 trials. Now, N-of-1 trials are more than just case reports. They're actually carefully constructed interventions where a single patient will be exposed. First of all, they'll have data collected at baseline, but then they'll be exposed to a treatment. And that treatment the effects of that treatment will be measured using a quantitative outcome measurement. And then repeated measures will be taken as that individual is either exposed to intervention, followed by washout, placebo, followed by washout. And what this does is it allows us to potentially use an individual as his or her own control and allow us to really determine if a given treatment is effective by comparing that individual's response to their response before or with no treatment. What's exciting is that these types of N-of-1 trials may also be amenable to therapeutic intervention. And so although I've been focused mostly on medical interventions, over time we may see a shift and therapy interventions could actually be increasingly guided by personalized factors. So think about different types of therapy, different approaches being utilized and matched to the patient that would benefit from that particular therapeutic intervention. All right, I'm going to share with you guys over the next few minutes some hot off the press data, and this was actually just presented by my postdoc Sarah Lewis at the American Academy of CP and Developmental Medicine conference. But Sarah has really helped to lead this project along with a number of other thought leaders in CP genetics, and asked the question, how might a genetic finding influence clinical care now? Not in the future, not someday, but right now. And so I'm going to skip through some of the details, but essentially what this effort involved was a modified Delphi using a series of expert curations with our panel, and a review and analysis of published data. And so this allowed us to look at close to 2,000 individuals who had undergone genetic sequencing. And what Sarah's is showing is that so far, out of these 1,841 patients that underwent sequencing, either on a research basis or a clinical basis, approximately 1/4, fully 26.7%, had a genetic cause for their symptoms identified. So this goes back to the idea that genetic causes represent a substantial proportion of CP etiology. How much? Roughly a quarter. The group through a subsequent analysis that looked at the different interventions that might be available for individuals that tested positive for a causative genetic finding. And essentially what she did is helped the group to classify the different types of findings. We looked at findings that targeted disease mechanism. We looked at findings that led to an opportunity to prevent adverse outcome. We looked at specific symptom management that essentially would allow us to reach for the best treatment first. And then we also looked at opportunities that might be coming down the pike in the terms of up-and-coming clinical trials. And remarkably, what the data here showed was that of the individuals who tested positive for a genetic finding, fully 25% of the genetic findings would all actually lead to changes in clinical management right now. So fully a quarter of the individuals who tested positive for a genetic etiology or cause for their CP would have a precision medicine treatment available currently. And that a substantial proportion also were being developed. But nevertheless, I think it also bears mentioning that still, for the majority of patients who have a genetic cause for their CP identified, this is not expected to change management currently. So looking at this in another way, what Sarah did was essentially mobilize the team, which included genetic counselors, neurologists, developmental pediatricians, and research geneticists. We drafted a series of rubrics that were modified from an existing framework that was developed by the ClinGen collaborative. We held meetings to discuss the approach. We developed rubrics and then performed individual scoring and analysis. And where this led us was to this schematic right here, which shows us that for individuals that were tested as part of all of these studies combined, you can see that about 3/4 had no clear genetic finding, no clear genetic cause for their symptoms. However, about a quarter of those individuals did. And that of those, that fully 7.1% had actionable genetic findings. And so again, these were findings that would be anticipated to change care right now. Sarah's also led the group through a series of further analyses that have looked at the risk versus the benefit of these potential precision medicine interventions. And so over a series of iterative meetings, we've been able to develop these rubrics where we've classified outcomes. We've looked at the potential risk and burden of interventions, and we've also looked at the impact of a given intervention. And so what you can see is that these scoring rubrics have been developed such that as you go in this direction, there's a relative benefit to patients that will be seen with higher scores. So I'll explain that in a moment. What this really comes down to is that if you look at the potential outcome, so for example, if a particular genetic cause for CP would lead to severe impairments if nothing was done differently, if there is a potential intervention and that potential precision medicine intervention is no or very low risk, and also if the impact of that intervention could lead to significant improvements or a complete avoidance of a bad outcome, those would all score high. And so what this analysis found was that the majority of the potential outcomes were in the moderate to severe range. And interestingly, the majority of the interventions for their risk and burden were in the mild to low risk range. So this indicates that there might be a decided benefit to utilizing a precision medicine treatment. However, an important caveat is that we need more data. We need more study in regard to precision medicine treatments for CP. And so if we actually look across the spectrum at the class of evidence, we find that less than half of the studies that were included in our meta-analysis really represented strong evidence studies. The majority of studies represented relatively weak evidence, often single case reports or case series. And so I think that this really argues that this is a potentially exciting time for precision medicine and CP, that we might have new treatments for some individuals with CP available to us now, but that we need to proceed cautiously because the strength of evidence we have for these interventions is relatively weak. So all in all, as a take-home point, I think from this particular analysis, you can walk away knowing that 26.7% of patients had a positive genetic finding. And of those individuals that had a positive genetic finding, fully 30% of them had potentially actionable genetic findings that could change their care right now. And again, this represents about 7% of the total CP population that was seen in these cohorts. Putting it into other terms, though, if you consider that there's roughly 1 million individuals with cerebral palsy currently in the United States, this means that if genetic testing was performed for every individual in the United States, this could impact potential care for up to 70,000 people with CP. I think that actionable findings can target primary disease mechanisms, they can create prevention opportunities, or they can inform particular symptom management. And also, as a take-home, in regard to patient impact, most of the untreated outcomes would be moderate to severe, while most of the interventions only create a relatively mild risk or burden. Nevertheless, less than half of the actionable findings are supported by high-quality evidence. All right, so I'm going to use just the last few minutes to talk a little bit about knowledge transfer aspects of genetic findings in cerebral palsy. And this really gets to the practical aspects of implementation. And I have to say, I've been approached by a number of wonderful colleagues who say, hey, I'm really interested in this genetic testing for CP stuff, but this is well outside of my comfort zone. And I think that this is something that although it represents an opportunity, it also needs to be considered cautiously. And so there are a number of important caveats to consider. Again, this is from Julie Cohen's, but it's important to recognize that genetic testing does not give you all the answers. In many cases, it can still be inconclusive or unrevealing. As you saw just a moment ago, genetic diagnoses may not change anything that we're doing for that particular patient at this point in time. It might not allow us to have too much insight into what their future looks like. And it's possible that although we're getting better and better at classifying genetic variants, we might not know what an individual's genetic findings mean for that person. There's potentially negative emotional responses to the results. There can be unexpected implications for family members. And there's also potential concerns about genetic discrimination and data privacy, although these are protected by federal law, the GINA Act. So I wanted to at least introduce a starting point for incorporating genetic testing into your practice for those of you that this might apply to. And I really think that the genetic testing is probably best going to be either associated with a genetics professional, a clinical geneticist or genetic counselor, or with the diagnostic home for individual with CP. So the first question is, are you comfortable with genetic testing? If the answer is yes, then you're in luck. And I think, as I mentioned earlier, that there's tiered testing with CP gene panels and whole exome sequencing currently widely available. If you're not, that's not necessarily the end of the road. And there are educational offerings. There are papers that are being written and have already been written. There's CME that I think is going to increasingly be offered. And there's also consultative support in the form of clinical geneticists and genetic counselors. So just because these specialists can't see every patient doesn't necessarily mean that they can't nevertheless serve as a resource for the patients that you care for. A couple words on variant interpretation. This means that a particular genetic finding might be really pathogenic, meaning might be clearly causative of an individual's symptoms. On the other side of the spectrum, though, it's also possible that a given genetic finding might be benign and might clearly not be the cause of symptoms. However, I think both of these are areas that clinicians are relatively comfortable dealing with in many cases. What can be even more challenging is when you end up in the yellow zone and it's uncertain whether a particular finding actually represents the cause of an individual or not. This is one of the current pitfalls of genetic testing, but most genetic testing companies are really good about helping to guide the ordering clinician through this process. I think it's important to recognize that genetic testing is seldom negative, but nevertheless, we fail to find a definite cause for individuals with CP, even among those that we think probably do have a genetic cause for their CP. We fail to identify that cause more than half the time. And so for this reason, because we don't know what we don't know, it's difficult to conclude that genetic testing is negative. My laboratory and many others are still actively engaged in discovering new genetic causes for CP. And we are literally discovering new causes for CP as often as every month. And so this is a rapidly growing area. As I mentioned, those variants of unknown significance can be quite tough. And this really is referring to those variants that fall in the yellow zone, not able to be classified as pathogenic or likely pathogenic or benign or likely benign. These variants of unknown significance, they do exist. They can be quite challenging, but one of the techniques that can sometimes be helpful as a way forward is a so-called segregation analysis. So if you have the ability to test that individual's mother and father, you can also see if they carry that same genetic variant. If those individuals are healthy or if they have CP, determining whether they have that variant can be helpful and to decide if that variant might lead to the CP or not. In the end, despite all of these uncertainties, I think that you can't go wrong as long as you remain fundamentally family-centered. Be honest about what you know and what you don't know. Be honest about what the field knows and what the field does not know, and about what genetic findings may or may not mean for a given individual. I think it's always important to attend to parents' emotions and provide support, offer perspective while being honest, making sure that you engage the parents in a dialogue, that you're comfortable with some degree of silence, and you give the family a chance to talk. It's important to check in with the family throughout the discussion, to use common terms that are easy to understand. Ask the parents what they would like and what might help them. But provide them with the most up-to-date information possible. Give them balanced information. Don't sugarcoat things. but don't paint a doom and gloom picture. Be honest again about what we know and what we don't know. And provide this information in a written form because they're not going to remember everything you say. Outline your follow-up plans and give them resources. Allow them to connect with other families and be part of support groups when they're available. All of these things have been endorsed time and time again by families as being something that they evaluate in conversations with their providers. So with that, I'm going to wrap and take any questions that you have. I know I've covered a lot, but I'm so very grateful to Armando, Valerie, and Tara and the other organizers for giving me the chance to speak to all of you. This work would not be possible without my fantastic lab that you can see pictured at the top, my wonderful family that you can see with the bluish tint on the bottom left, and all of the wonderful organizations that have supported our work or another, but a special thanks at the very top to UCP. So thanks so much.
Thank you so much, Dr. Kruer. What a wealth of information in that presentation, and I think I really loved your last slide and the summary of how to best care and treat individuals with cerebral palsy. So at this time, I'm going to start kind of going through the questions that have come up in the chat. If anyone has questions as we go, we are going to monitor this closely. So please use the little icon at the top to place your question in there, and then we'll read them off as they come in. So the first one, how effective is NAPA, N-A-P-A, in improving the quality of life of a 5-year-old with CP?
Yeah, that's a great question, and I can only speak from my experience as a clinician and say that some families have found it very valuable, but I think that we don't have very much data to guide us on that, and it's something where the intersection with genetics simply hasn't been explored.
Great, thank you. Next question is, which common comorbidities are believed to be genetically linked to CP?
Great question. All of them. And so we know, in fact, that epilepsy has a very strong genetic basis. Although quite interestingly, if we rewind a couple of decades, it was widely argued that epilepsy was not genetic. And so we now know that that is not the case, and that genetic causes of epilepsy represent a very important contribution, although certainly not the only contribution. We now know that genetic contributions to autism, to intellectual disability, also exist. And what's quite interesting is trying to untangle how sometimes a misspelling in one gene might lead to both CP and these other conditions. And we think that this occurs because that gene contains instructions that are crucial for early brain development. And so you can think about it that as a child's brain is developing, and these literally billions of different brain cells are making billions of connections, if those connections are not directed in quite the right way, that could certainly impact neurodevelopment. And so we see that impact playing out in different aspects of development, but there's quite an overlap between the different neurodevelopmental disorders.
Great. Next question. Can you tell us about the CPRN study?
Yeah, so it's one of my favorite topics. The CPRN is something that I've really enjoyed being a part of over the last several years. It's been a collaboration between my research group in Phoenix, which serves as a CPRN site, but the entire CPRN network. The network is really a coalition of different centers of excellence across the United States in CP care. And the common goal of the CPRN is to try to establish gold standards of care for individuals with CP. And so as part of that, there are opportunities to directly join our study through the CPRN network. If you just were to Google CPRN genetics, you can find more about it. But essentially, individuals that are seen at any of the participating CPRN centers, if they have a diagnosis of CP, they're eligible to participate. And it's painless. We use saliva as a source of DNA, and we are able to share the results of the genetic testing with the family if they're interested in receiving those results through a personalized report. And so for anyone who's interested, please just Google CPRN and genetics, and you'll learn more.
Super. All right, let's see. If I want to test my child with CP, what steps should I take?
Yeah, so I think you have a couple of different options. I think that if you go through clinical testing, meaning that finding will go in your child's medical record, that's something that I would suggest you go to your child's primary CP doc, whoever that is, and you ask them about genetic testing. Also, if you're interested in participating in research testing, which is sometimes able to find new things, still actively discovering new causes of CP, as I mentioned, then you can also, you're welcome to visit my laboratory's website. It's kruerlab.org.
Great. All right, let's see. How early, what age, or at what point should conversations with families start on DBS?
It's a great question. And here's where I think you're going to get different opinions from different docs, because all of us have individual experiences with our patients and their families. And here's where coalitions like the PDDBS Consortium can be so valuable in trying to give us more evidence to help guide those discussions. With that said, I think that we're starting to think about DBS earlier and earlier. And I think as a good rule of thumb, if your child has tried and not had success with 2 or more treatments, whether those be medication treatments or injection treatments, that I think it's very reasonable to bring up DBS as a possibility with your child's doc.
Great. Looks like one more question here. Does genetic testing have a purpose for a child that has spastic diplegia with seizures? Spastic dysplasia. Yep. Does genetic testing have a purpose for a child that has spastic dysplasia with seizures?
Okay. In general, yes. Just because it sounds like there are some things that are known about that child's symptoms and that child's presentation. Again, thinking about that picture of all the different individuals, all the different colors of CP, I think that description tells part of the story, but it doesn't necessarily tell us why your child has those symptoms. And I think the fundamental role of genetics is to try to help answer the question as to why.
All right. If your child was tested a while ago through your work, when should they be retested, if at all? I'm not sure what through your work means, but if your child was tested a while ago through your work, when should they be retested, if at all?
Yeah, so what I'm interpreting that question to mean
by
is,
Dr. Kruer. tested by you?
Yes. So I mentioned briefly that genetic testing is not genetic testing, meaning that things are always evolving and our knowledge is always increasing and the technology is always improving. So even if genetic testing was done in the past and it was negative, it may be reasonable to think about doing it again. But like anything else in life, you don't do the same thing and expect a different result. You have to do something different. And so for those families that have signed up for our studies, we are moving on from whole exome testing to whole genome testing, which is a more comprehensive form of testing whenever possible, but that's also subject to funding. So, just get the word out. We need more support for CP research. We would love to be able to test everybody at the whole genome level that's been tested by our earlier exome studies, and nothing was found.
Right. I'm not sure if others are having a little bit of difficulty with the sound. I think he finished talking.
Did you hear me?
I heard a little bit of the end. Would you mind just repeating like the very end of what you said? It went out on my end. I'm not sure if it went out for everyone else.
Okay. It's funny, Tara, because you're sounding a little choppy to me too. So
okay, maybe we're just too far away. I don't
know. What the question was basically asking when to think about repeating genetic testing, and I think that the technology is constantly improving. Every couple years, 2 to 3 years is reasonable as a time frame, and for testing that was in my laboratory, we're now using a more advanced technology. So we're moving from whole exome to whole genome testing, which is almost like looking at things through a digital camera with a much higher megapixel resolution. So basically, the newer technology allows us to take a deeper look, and we might find things that we couldn't see before.
Perfect. Thank you. Another question here. For the layman, including me, is the field moving away from the use of the term intellectual and developmental disabilities toward neurodevelopmental disabilities, and why? So are we moving away from intellectual and developmental towards neurodevelopmental disabilities?
I don't know that we can say that we're moving away. I think the use of the terms has gradually shifted over time. And I also think it depends what your background is. Certain terms are used more in educational and services areas, and other terms are used a little bit more in medical terminology. But I think as long as we know what each other are talking about and have that common language and that dialogue, I think that that's the crucial thing.
Great. Another one here. What is your hunch about the true percentage of individuals that have a genetic cause to their CP?
That's I've been saying roughly a third for a while now, and I'm going to stick to that. But I will say that one of the areas that really fascinates me, that we're just starting to get into, is trying to understand why some kids have, that don't have a clear genetic cause for their symptoms, why they have a difficult start to life. So for example, why are some kids born so prematurely? Why do some kids have difficult deliveries with lack of oxygen or bleeding in the brain? And I think that that's an important question. I think it's obviously not going to be a simple answer, but there's some very preliminary data that suggests that if a child does have a genetic mutation, that predisposes them to those difficult starts to life. Now, that doesn't mean that every child with a difficult start to life will have a genetic mutation, but I think it's going to explain more of the story, although I think the story is going to get more complicated.
Very good. That looks like I'll give people a few more minutes here to enter any question. That was the last one that I see on my end. So again, I want to thank Dr. Kruer and UCP of Central Arizona, Gillette Children's, and the UCP Research Committee for pulling together this professional learning series. And maybe I'll have you, Dr. Kruer, stop sharing your screen. I can still follow the chat, but we can talk a little bit about our upcoming presentations. And I won't remember the titles without sharing. Okay, can people see that?
Yes.
Okay, perfect. So I'm not seeing any more questions, so I'm gonna just keep reading. I'll give people time to enter. So after tonight's presentation and within the next week, you'll be receiving a follow-up email that will include a survey about today's presentation, and that's really helps us guide and tailor our future presentations. So we appreciate all feedback. And then individuals eligible for CME will receive that certificate. The link to the recording of tonight's presentation and previous ones can be found on ucp.org. And if you click at the top, you'll see a research tab. And if you scroll down, you'll see the professional learning series. And there you can find previous recordings. I believe this is our, oh gosh, don't quote me, 5th or 6th. I know, Dr. Kruer, you've done 2. So Valerie, jump in. I think this might be 6. So upcoming, our next one is December 6th with Diane Damiano, New Frontiers in the Mobile Brain Imaging in Robotics and Pediatric Neural Rehabilitation. And Dr. Kruer did mention her study in one of the slides during his presentation. So it'll be really nice to have another clinical researcher. And then in March 9th is Karen Herbster, What to Know About Cerebral Visual Impairment, Evaluation and Treatment to Improve a Child's Functional Performance. So those are the next 2. Registration will come to those that have attended tonight in an email. You will get an invitation with a registration link. Otherwise, you can always find this information on the ucp.org website. And we welcome any comments or feedback to future presentations, tonight's presentation, and you can email Valerie or myself, and our emails can be found at the bottom there. And Josh put in the link to where you can find the learning series. Okay, I have one more question. If we can clearly surmise our son has CP due to low oxygen levels due to a congenital heart defect at birth, do you see any reason a pregnancy with his brother's wives need genetic review? Do you need me to read that again?
Please.
Okay. If we can clearly surmise our son that has CP due to low oxygen levels due to a congenital heart defect at birth, so low oxygen due to the heart defect at birth, do you see any reason a pregnancy with his brother's wife would need genetic review? I don't know if the brother has ever had any genetic.
That's a little convoluted, but if I understand correctly, the question is about whether a family member might be at any risk. And I think the further away that you get, and the more series of events that need to occur for something to happen, the lower the risk. But I guess it all comes back to what the family's goals are. And even with congenital heart disease, for example, the question will apply as to why. Why does a given child have congenital heart disease? And we know that, in fact, I'm starting to sound like a broken record, but genetic mutations are a frequent cause of congenital heart disease as well. And so knowing what the implications are for another family member may be one reason to think about genetic testing, but that's a family decision.
Did that answer your question, Jane? Yeah, so does his brother's wife need review? So yes, thank you, yes. All right, well, it doesn't look like there are any more questions. If anyone does have a question down the road, you can email Valerie or myself, and we will pass that along to Dr. Kruer for a response. But otherwise, thank you so much for attending, and have a great rest of your afternoon, depending on where you are, or evening. Thank you.
Thanks, everyone.